main talk tonight is about surgical solutions for common spine problems, but I'd like to just tell you a little bit about my journey and my own biography a little bit here. So you might be able to tell from my voice, perhaps, that I'm not from here, perhaps, but I grew up in a small town up here in Cass County, Texas, called Atlanta. And from there, I was able to get a scholarship and go on to undergraduate school at University of Texas at Austin. And from there, I then also completed my medical school at the University of Texas Medical Branch in Galveston. And once I completed my medical school training and received my doctorate degree, I went ahead and started my journey with the Air Force and spent about 12 years doing my residency training in the Air Force at Wilford Hall Medical Center in San Antonio, as well as completing my residency and internship training and even my fellowship while there. And then I was an assistant professor in my training program for a few years before I got out. During my time in the Air Force, I did spend 1 year up in Milwaukee, which is where I performed my spine fellowship, which is just an extra year of training. And of course, Milwaukee was where they developed the Milwaukee brace, which was instrumental in treatment of scoliosis many years ago. And this was an interesting time for me to learn about spine surgery. And I credit my mentor, Dr. Howard Ahn, for teaching me about how to treat patients compassionately as well as effectively with surgical treatments. Once I got out of the Air Force, I spent a little bit of time in Western Tennessee in a small town called Jackson, Tennessee. About 7 years I spent there, and this was between Memphis and Nashville, and I was the only orthopedic spine surgeon between those two areas, and I was at Sports Orthopedics and Spine at that time. And then, as lo and behold, things come along, and I had a great opportunity get presented to me to come to the great Southwest and live in this fine area of Northern Arizona and experience all the things that it has. And I joined Northern Arizona Orthopedics, which is a group that's been around for almost 50 years. And it's been my honor and pleasure to work with these doctors. And we love to take care of our patients and do these type of things to educate you. So that's a little bit about me. So let's kind of get into the talk here again. So the way I'm going to approach this is I'm going to kind of go through this as if I'm going to assume that you're someone that I'm speaking to about a spine problem. And for me, it always starts with learning about the anatomy, which if you don't understand the anatomy as it pertains to your spine problem, then you really can't figure out what to do. So anatomy is I would say, the foundation of learning about spine. Then we're going to talk about some common spinal diagnosis. Now, there's lots of things out there on the spine, but we're going to talk about the 3 most common things that I talk about, which I actually see patients for, which is herniated disc, spinal stenosis, and the final condition called spondylolisthesis. Now, I know these are a lot of words that you may not know about or heard about, so I'm going to try to explain them to you so that you can understand them at a basic level as it relates to your anatomy and all the imaging studies that we are going to show you tonight. And then I'm going to talk with you about the common surgical solutions. There's some old surgical solutions. There's some new surgical solutions. There's some really advanced ones. And then there's some interesting ones to treat these common spinal diagnoses. So hopefully these will meet these 3 objectives for you and give you opportunity to talk about them. So let's move on to anatomy. So anatomy is probably the most important subject that I learned in medical school. And without anatomy, particularly as an orthopedic surgeon, you can't really be effective at what you do. So hopefully you can see this mouse here. I'm going to use it to kind of point out certain things on the slide. And so the anatomy is, this is just a common side view of a spine, okay? So your head sits up here, but it's not here on this image, obviously. So your spine has 7 vertebrae in the neck. Then you have 10 vertebrae in the thoracic spine. So this is called cervical. This is called thoracic. And then you have the lumbar region, which have 5 vertebrae. And then you have the sacrum, which has anywhere from 4 to 6 segments that are all fused together. So lot of times when you get your radiography reports, they may mention things such as lordosis and kyphosis and various words that may be a bit mystical to some of us out there. So let's talk about what lordosis is. So lordosis is this curvature that looks like a C. So there's two areas of lordosis. It's the cervical spine and the lumbar spine, and two areas of kyphosis, which is the thoracic spine and the tailbone area. This actually forms the shape of your buttocks. And also you can see the close proximity your spine has to this big red thing right here, which is called your aorta. And each level has a little blood vessel that comes out of it. And of course, here, the other thing I want to point out is that your spinal cord starts up here at the base of your skull, and then it ends right here at about L1. And then all of these little string things come down that look like spaghetti or filaments or electrical wires, if you want to use that analogy. And this is called the cauda equina, which stands for horse's tail. So this is kind of the, the basic landscape of your spine that we talk about. Let me go back here 1 second. All right, so this is a picture of what's called the vertebral body. So this is representative of everything that's in your spine. And so when you read, and many of you probably get your MRI reports or CAT scan reports or X-ray reports, and you're reading what the radiologist says, and they use a lot of these terms when they describe what's going on. So the vertebral body is this part right here, which is the main structural part of the spine. And then you may see a term called the pedicle, which is this part of the bone that comes off like a stem. And then you're going to hear the term lamina quite a bit, so lamina actually means shingle, if you think about it that way. And many times you may see on your house, you have shingles on your roof. They call them laminated shingles. That's because they overlap, and that's what a lamina does. It overlaps. And then the lamina on each side, there's one on each side, joins together and forms the spinous process. And this is the only part of your spine that you can actually feel if you were to touch your back. And then the last thing to point out is the transverse process, which just means it projects out to the side. And all of these things have muscles and tendons and ligaments that attach to there. And then, of course, the most important part that has to do with nerves and spinal problems is the vertebral canal, which is, we're going to go into that next and show you the contents in there. But that's what all these terms apply to when the radiologist may point those out to you in their reports. All right, so now we're going to take that same slide and I'm going to add the soft parts to it. So this is what the disc looks like. It's the soft part, and it actually connects the spine, each of the vertebral levels together. And then in that vertebral canal lives your nerves. So the vertebral canal only has just enough room for the nerves, the little sac that goes around the nerves called the dura, the spinal fluid, which lives around the nerves. And then you have all the nerves go through this canal, and then they exit at each level. All right, so this is just a bigger view of the lower back, which is where most of the problems that we deal with are there. But this, again, is a good representation of the things that we see. So one thing I want to point out to you, which is important, particularly when you're doing certain approaches to the spine, is we talked about the vertebral canal, which is the main canal, but there's also a lesser canal called the neuroforamen, which is right here, and your nerves exit out through that. So again, here's the transverse process. Here's the spinous process, which is here on this frontal view, and then also here on this side view. And then you can see all of your discs that connect your spine together. And this is the basic structure upon which things can happen to your back over time as we get older. All right, so the first diagnosis we're going to talk about is the herniated disc. Your disc is like a tire. It has a soft core that's like air in the tire, and then it has a tough outer ligament area that's like the radial steel bands in the rubber of your tire. This soft core has a name, and it's called the nucleus pulposus. The purpose of the disc is actually to expand and contract, and acts like I think many times like a hydraulic bearing, in that it changes its size based off of how much load is applied to the spine whenever you do activities. And it's actually like a link for the bones in your spine. Over time, it can get wear and tear, it can age, and it can actually abruptly fail with the right amount of force applied to the spine. And when that happens, the soft core kind of blows out through the outer fibrous band, and it goes into the spinal canal, which, as we said earlier, only has so much room for the nerves. And then it causes pain down your leg or your arm. And then it causes dysfunction, such as weakness or numbness or trouble standing and walking. So that's basically what a herniated disc is. So these pictures give you a pictorial of what the herniated disc is. So again, here's the soft core. That's like the air in the tire. This is the outer ligament band. It actually has a name called the annulus fibrosus. And you can see that there's been a tear, and you got this blowout of material right here that's pushing on the nerve. And you can say, well, that's got to hurt. And so that's why you have your pain in your leg, in the lower back, and then the cervical spine, there is the rupture. But what you're dealing with here is the spinal cord. And the spinal cord is not as forgiving as the lower lumbar region, because here it's all solid. And here you have the benefit of a more spinal fluid. So this is kind of what a herniated disc looks like on these pictures. So now let's move on to the MRI, because this is what's important for us to determine what's going on in your back. So these are two common images that I look at in the spine. This is a cross section of this image right here. So this is to point out the anatomy. Here's the lamina. Here's the spinous process. Here's the vertebral body. Here's your spinal canal. These are also called facet joints. And so you can see that you've got this mass right here that's impinging on the nerves. And here's your nerves are all squeezed up together right here. And this is just a side view of this same herniated disc. And you can see how it's impinging on the spinal canal, which runs from here to there. And the white stuff here is actually your spinal fluid. So that's what an MRI, this is a typical MRI image of a herniated disc. All right, so now that we know what this is all about, what can you do about it? Well, let's talk about what the solutions are for herniated disc. So from a surgical perspective, there's really just kind of two ways to take care of this. The first one is called the microdiscectomy. And what that means is that, so first off, I want to tell you, ectomy means to cut away. So anytime you see that word, something is being removed. Micro just means we're using a microscope or some level of magnification. And of course, the disc is self-explanatory. Usually this is done through a 1-inch incision, and it can be done with or without a tubular retractor. And I'll show you what that is here in a minute. Excuse me a minute. And of course, this uses a magnification with a microscope so that you can see all the anatomy. A more advanced technique and an elegant solution in the right patient is called the endoscopic discectomy. And this is done through an 8mm incision and actually uses a TV camera on the end of a wand. That's called an endoscope. And this is very much like what is done in knee arthroscopy. And this provides a direct visualization of the nerve and the disc and the space around the nerve, similar to a microscope, but it's a much more magnified scale. So the first discectomy that was ever done, I think it was in 1942 by a couple of surgeons named Mixter and Barr. Of course, at that time, they didn't have all of the imaging and technology that we do now, but it's been around for a long time. And even endoscopic discectomy is not really all that new. It's been around probably for 2 to 3 decades, but the technology has gotten better in that it can be helpful. And again, in the right patient, this could be very minimally invasive and provide relief. So those are kind of the two main things. So let's talk about the lumbar microdiscectomy. So what you're doing is you're taking a tool like a drill. I like to think of it as like a high-speed Dremel tool, and it actually has a revolution of about 75,000 RPMs, and you use that to drill out this bone so that you can make a window into the spinal canal and see where the nerves are. So whenever you hear somebody saying they're going to drill out your bone or something like that, that's what they're talking about. So this is just a cross section of this image. So you can see here, this is a little tool that we put into the spinal canal that moves the nerve out of the way. And you can see that this is where the tear was in the disc. And here you're removing that chunk of disc and it's taking pressure off the nerve, and the nerve feels a lot better. So you can also do that same procedure, but you can also do it through a tubular retractor where you put in and it actually goes through the muscles without cutting the muscles. So that's really the only difference between the two, is that this may be a little less invasive and traumatic to the muscles, but either way you take care of it, you still get the same outcome. So this is what, when we say a tubular retractor, this is what we're using. And a retractor is basically just a tool that you use to move things out of the way. Of course, here you can do a microdiscectomy using an endoscope. So this technique, you actually go through the side of the spine, through the neuroforamen that I talked to you about before, and you're actually operating through a very small tubular retractor also, but this is what it looks like, which is very similar to an arthroscopy that you would use, and you work all the way through this channel. So I have a video of what a microdiscectomy is done using an endoscope. So I'm going to run this video here in just a second, but let me orient you to what you're looking at. So this is the nerve. This is the visualization that you can see. This is bone, and the patient's head is over here. Their feet are over here. And so the disc was actually sitting right here. So I'm going to run this video. It's very short, and you're going to see it pulsatile, which means that we've got it all decompressed. And this is just a little bit of fat around the nerve. So let's watch this real closely here. So again, you can see the pulsations, and then I'm just probing around here, making sure the nerve is freed. And this is all the disc fragment that I pulled out on this particular case. You can also do the microdiscectomy through what's called the Interlaminar Approach, which actually is the same approach you would do for a standard microdiscectomy. And again, we're operating through a tube, but again, this is highly magnified. So what you're going to see is this probe is going to be kind of moving. You're going to see the nerve right here, and you're going to see the disc. And this is just going to kind of demonstrate the technique of how you expose the nerve and the disc. So let's run this video. So again, I'm just probing around the nerve. So again, here's the head over here, and this is the feet down here. And the nerve is very large in this. This is actually an L5S1. And then as we move the nerve out of the way, I'm going to drive in the tubular retractor. And the retractor actually serves as a way to keep the nerve out of the way and expose the disc. So you're going to see it go in, and then I'm going to spin it around as it moves the nerve out of the way. And then there's the disc right there. And then that's how you go and take it out. It looks kind of like a pimple, if you pardon my crude speech there, but that's kind of what it looks like. All right, so anytime we do surgery in this day and age, we have to talk about what the outcomes are of treatment, because we're kind of graded on that. Why would you do surgery if you're not going to have a good outcome? So the outcomes that I use the North American Spine Society's evidence-based clinical guidelines. And when you look at those for the treatment of herniations and radiculopathy, the performance of surgical decompression provides better medium-term relief, which is up to 1 to 4 years, when compared to just medical or interventional management of patients who have pain down their leg, which is called radiculopathy. And it doesn't mean that these don't work for patients, but if you get to the point that your symptoms are severe enough, then there's no point in doing further medications or epidural steroid injections. You should go ahead and the surgery could definitely help you get better. So this is good to know that you can at least get reasonably good improvement. And the other thing you need to know about the decompression is that it can also provide longer than 4 years of relief. However, it's not a back pain operation. And so about 25% of patients can still have chronic back pain and leg pain. So that's something you just have to be aware of when you talk over with your surgery. And there is a potential for a reherniation rate, which means that the disc herniation could come back at about 12.5%. When I was a resident in the military, we did some research and we created a model where we were able to make a hole in the disc and then measure it over time to determine its healing. and actually found that it takes about 3 months for the hole in the disc to heal up to about 80% of its strength before. So that's kind of the rule of thumb that I tell patients, that it takes about 3 months for everything to kind of heal up deep down inside. But nonetheless, herniation rates do happen, and we have to be prepared for that. All right, so that's the herniated disc of the lumbar spine. Let's talk about the cervical spine. The stakes are a little bit higher here in the cervical spine because we're dealing with the spinal cord. So all those nerves that are in your lower back, they have to start up here in your brain, and they come all the way down through here. So again, pointing out the anatomy, this is the cross section of this image right here. So here's the joints, here's the lamina, here's the spinous process. These are the facet joints. Here is that neuroforamen that I was telling you about. Here's the disc. Here's your spinal cord. And here is this mass poking out into the spinal cord, actually putting pressure on it. And so, as I told you before, the vertebral canal only has just enough room for the nerves and the little blood vessels and the spinal fluid. So here you can see that this is pushing out on the spinal cord and deviating it. And you don't see the nice thin line of the white spinal fluid in that area. All right, so that's the herniated disc in the neck. So what are your solutions for that? Well, they're a little bit different, and there are basically 3 different types of procedures. The gold standard is what's called the anterior cervical discectomy infusion. So anterior means that I'm coming in through the front of your neck. And then, of course, we already talked about discectomy. And then, of course, fusion is meaning that I'm taking away some motion at that level. And, you know, when you mention the word fusion, a lot of people kind of get nervous about that and think they're going to have a really stiff neck, but that's not really true. One level of fusion only takes away about 10 degrees of your motion. And most people, after they have 1 or 2 or even sometimes 3 levels of fusion, they don't even really notice that they have that much loss of motion. And that's because half of your motion comes from the very top of your spine, which rarely ever gets surgery. Another option, which is also, I think, a very elegant operation, is called artificial disc replacement. So what does this mean? It means that you take the disc out, but you put something else in it, kind of analogous to a total knee or a total hip. And the benefit of this is that it actually preserves motion, and it is FDA approved for up to 1 to 2 levels. And then the final solution, which does not have any implants, there's no fusion, and it does preserve motion. It's called the posterior foraminotomy and discectomy. So what's the difference between an ectomy and an otomy? Well, otomy means that you're making an opening, but you're not really cutting away. And foramen means that's the window where the nerve goes out. So you're making an opening in that window to take out the disc. However, it's not for all disc herniations in the neck, because if the herniation is pressing directly on the spinal cord from the front to back, you can't get to that safely without retracting the spinal cord, and the spinal cord does not like to be moved. So this is only for herniations that are kind of off to the side. And of course, this surgery can be outpatient surgery or an overnight observation. Even lumbar disc herniations can also be done as outpatient surgery. And in the life of COVID, we've been kind of accelerated with our move toward more outpatient spine surgery. And many times I can discharge patients directly out of the recovery room safely. So that's, I guess, a silver lining with this life of COVID that we live in, that it's making us improve and adapt our surgical procedures that are better for the patient. So the next thing, I want to talk about a little bit about the anterior cervical discectomy infusion. We also call it ACDF. So this is just kind of, forget about all these words, don't even try to read them. But what I want to point out is that in the neck, there's a very special plane that we have to go into between this muscle on the side of your neck, which is called the sternocleidomastoid. And then we have to go in between the mid structures of your neck, which includes your airway, which is your trachea, and your voice box. This right here is your food tube or your esophagus. And this right here is called the carotid artery in your jugular vein, which is the pulses that you feel in your neck. So we have to go in between this stuff and this stuff to get all the way down to the front of the neck. Fortunately, your neck is designed in such a way that it gives us easy access into this area safely. So this just kind of shows you what an anterior cervical discectomy infusion is. We take out the disc, which has been removed here, but then you got to put something back in place. in this instance, we're using what's called an allograft, which is actually a piece of bone that someone has donated, much like somebody donates their heart or their kidneys, and you put that in place, and then you secure it with a metal plate and screws. Now, when I learned how to do this over 27 years ago, we weren't using metal plates like this. The metal plates were only used for people that had broken necks. But somebody got smart and did some research on this, and they found that actually if you do the anterior cervical discectomy infusion and you add a metal plate, the outcomes are actually better, with reduced chance that this piece of graft will spit out like a watermelon seed. And it also makes the fusion go faster, and you don't have to wear any kind of a neck collar most of the time. So this is a patient of mine that I've done several years ago. And in this one, I actually did use an allograft, which is right there. And you can see how the plates look. And you can see that you still have good alignment and all your other discs are in place. All right, so let's move on to artificial disc replacement. There are many of them out there on the market. This is just one of them, and this is the one that I use. And it kind of uses the similar analogy like you would with a hip replacement. There's a ball and there's a socket, and this kind of pivots on that ball and socket and preserves motion. In this patient, you can see that if you imagine it, you can see that this little line here changes. It gets bigger in the front when you extend the neck, meaning go back this way, and it gets smaller when you go this way, which means that it moves. So what's the benefit of doing an artificial disc replacement? Well, in the long-term outcome, there may be less chance that this disc here will wear out or this one will wear out. And that's what happens with fusion. Sometimes over time, other discs can wear out maybe a bit quicker. And then the final procedure, which is called the foraminotomy, is done through the back. So here, let's point out the anatomy again. Here's your joint. Here's the joint here. Here's the disc. Here's the back of your spine. And so you're going in this way, and this shaded area represents the amount of bone that you have to remove. And so here's your spinal cord. So if you had a disc herniation sitting right here, you can't get to that because the spinal cord doesn't want to be compressed. This is for disc herniations that live out in this area. And on this image here, this is just me looking down on this area. Here's the spinous processes. Here's that drill that we use to cut out the bone. And it looks kind of like a keyhole. Many people call this a keyhole foraminotomy or keyhole surgery because you're taking pressure off the nerve. All right, so again, in keeping with the theme of talking about herniated disc in the lumbar spine, we also have to have outcomes for the treatment of herniated disc in the neck. So surgical intervention is suggested to provide rapid relief of symptoms of nerve pain when compared to non-operative treatment, which is either medicine, physical therapy, shots in your neck and stuff like that. And also you have to know that whether you choose to do a fusion, which is the ACDF, or the posterior laminoforaminotomy, either one of those for the treatment of a soft disc herniation achieves pretty much the same outcome. So it doesn't really matter. What matters is what your surgeon's experience is with these different types of procedures. But it's good to know that when you take that herniation out of there, your arm pain gets better. And then they've also looked at, in these evidence-based guidelines, on fusions as well as total disc replacements, and for short-term outcomes for the treatment of a single level degenerative problem with your neck, they're the same. Gets rid of your arm pain. But it's the long-term outcome which may be a driver for artificial discs, because maybe there's less of a chance that you might get other degenerations. But again, not everybody's a candidate for artificial disc. And in my practice, most of my patients are more of a candidate for this than this. But again, you have to tailor your solution to the patient's problem. And then the good thing to know is that you can get up to 4 years or more favorable outcomes for the treatment of problems in your neck that cause nerve pain. And again, we're using the evidence-based guidelines for the North American Spine Society. Okay, so let's move on to the second common diagnosis. We've already talked about herniated disc. Let's talk about spinal stenosis. I'm sure many of you have heard that term before. So what does stenosis mean? Stenosis is an abnormal narrowing of a bodily canal or passageway. And many times when I'm talking to my patients, I like to use analogies to help them visualize what we're talking about. So I like the water pipe analogy or the hourglass analogy. So think about your water pipes. If you got an old house, they may have galvanized water pipes in that house. And if you live in an area that has a lot of hard water, then over time, that water is going to have minerals in it, and those minerals are going to deposit along that pipe, and it's going to narrow down that passageway. So you can imagine sometimes how hard that water has to go to squeeze through that. So that's what happens in stenosis. Your nerves are squeezing through that pipe. The hourglass analogy is pretty much kind of self-explanatory. You have the large bowl of the hourglass, and you have a little narrow spot where the sand runs through. And think of that part where the sand runs through as where your nerves run through. In the spine, this passageway is the vertebral canal, which we've already talked about, and only the nerves and the spinal cord live in that. So anything that takes up space in that area causes narrowing of the spinal canal. So what can take up space in the spinal canal? You can break your spine and bone could get pushed into there. We've already talked about herniated disc. You could get an infection in your spine that causes problems. You could get a cancer. There can be cysts that develop off of the joint. I have a picture of one I'm going to show you. It could be due to arthritis or degeneration. It could be due to too much fatty tissue in the spinal canal, or even blood clots can develop in the spinal canal and cause stenosis. The spinal stenosis can occur in the main central canal, which we've talked about, but also there's the lesser nerve canal, which I've talked about, called the neuroforamen, and this can occur anywhere along the spine from the top to the bottom. And of course, the main symptoms are usually nerve pain and dysfunction. And usually it gets better with rest and can be relieved with a change of position. But most of the time that people have spinal stenosis, particularly in the lower back, they're going to have increased pain with walking. They can't walk very far, but they might be able to ride a bicycle better. And sometimes they like to push a shopping cart. A lot of times they got to sit down or bend over to relieve their pain. And so in the cervical spine, there's a special form of spinal stenosis that can actually cause what's called myelopathy, which means that your spinal cord can be so compressed that you have trouble walking, and you can have trouble with your balance, and you can get weakness in both your upper and lower extremity. All right, so these are some pictures to show you about degenerative lumbar spinal stenosis. Again, here's our anatomy. I showed you this slide earlier. Here's the disc, the lamina, the joints, and the vertebral canal with the nerves in it. So when you get arthritis, you get these bone growths here. Now, a lot of times, if you read your report on your MRI or your primary care doctor, they tell you got bone spurs in your spine. Well, what the heck does that mean? Well, basically, it's just this arthritic change that kind of sticks out and takes up the space. Now, patients are really worried about the bone spurs in their spine, and it took me a while to understand what they were talking about. And so when a patient hears that they got a spur, many times they think about it as a sharp, sticky thing, like on the spurs that you wear on your boots when you're riding your horses, but it's really not a sharp, pokey thing. And so you just have to know that it's a form of arthritis that takes up space in the spine. So just know that we use bone spurs as kind of a way to make an image in your brain so that you kind of know, to hopefully relate to it. But that's what the bone growth is, and that's what the bone spurs are. So you can see the change in the spinal nerve compression here compared to normal. All right, so this is an MRI. This is another one of my patients. And so let's point out the anatomy. So here's the discs, here's the bones, here's the spinous process. And again, this is the only part of your spine you can feel. Here's your spinal canal. Here's all the nerves, the little strings that go down like spaghetti. And so this demonstrates actually the hourglass analogy. So these red lines show you where the front of the spinal canal is and the back. And you can see that there's a constriction here that this big red arrow shows you about. So you got to imagine your nerves are coming down here and then they got to squeeze through this tight spot right here. So here's a cross section of an MRI. So it looks kind of like that picture I showed you. Here's the disc, here's the joints, here's the spinous process. These are just all muscles that attach to your back. Here's the lamina. Here's the spinal canal, nice and open. Lots of water, which is your spinal fluid. These little dots represent your nerves. The nerves are coming out through here. But here, you've got all of these spurs coming off of this joint, which is severely arthritic. this is a normal joint. This is not. You can't even see the spinal fluid here because it's so compressed down that your nerves are all squeezed together. So you can understand how that might hurt. This is considered severe, by the way. All right, so I told you I was going to show you a cyst. So a synovial cyst means that it's a growth that comes off of a joint. You may have known people that have these cysts that develop on the back of their wrist, and it's called a ganglion cyst. But all that is a cyst that develops in someone's wrist due to arthritis. In the spine, when you get arthritis in your joints, and this is joint fluid here that's more than normal, these cysts can pop out and they take up space. So this arrow shows you kind of where it is. This is a patient of mine that I've seen recently. We're actually able to aspirate this cyst, but whether he'll move on to surgery or not, I don't know right now. But nonetheless, this is a special cause of spinal stenosis that causes nerve pain. All right, so as to continue the theme, what are your solutions for the treatment of spinal stenosis? Well, the most common thing that we do is called a laminectomy. Remember, I said ectomy is to cut away, and this can be done open or through a tube or even endoscopic, similar to what we talked about with herniated disc. Or it can be what's called a laminotomy, foraminotomy. Remember, I said otomy means just make an opening but not cut away. So this is similar to this, but on a smaller scale, and it can be done in certain patients. And then you can also use these things called interspinous spacers. You may have heard terms like X-stop or Coflex or Vertex. And these two techniques rely on open decompression where you're visualizing it. These techniques rely on indirect decompression, and I'll show you some pictures of those. And again, this can also be outpatient surgery or an overnight observation as well. All right, so again, we're going to do, this is an open laminectomy, or it can be done through a tube. It doesn't matter. So here's a patient with an MRI with spinal stenosis. This is all grown up and narrowed it down. And here you've had the surgery has been done and the bone has been removed, cut away. And you can see that the spinal nerves are actually, there's a lot more room here than there. So that's what a laminectomy looks like. And again, as I showed you on the herniated disc, you can also do endoscopic, interlaminar. So I'm going to run this video a little bit. So just to orient you, the patient's head is here, the feet are here, the patient is lying on their stomach. This is toward, this down this way is toward the middle of the spine. This up here is toward the outside of the spine. And right here is the lamina and the joint. So actually we're doing a laminotomy here. And this is a probe in the spinal tube. And what we're looking at here is a special ligament that you have to get through to get into the spinal canal. So what you're going to see is that this probe is making sure everything is freed up. And you're going to see the pulsations in the spinal canal, which represents the showing that's decompressed. So let's run this video here just a second. So again, just probing around. This is all bone. This is the ligament that goes into the canal, and you can see the nerves deep down. So I'm just kind of probing up under the bone to make sure it's all nice and free. And this is an interlaminar endoscopic. And again, this is not for everyone. Sometimes it takes longer to do this than to do it the standard way, but in the right patient, it could be beneficial. All right, so we talked about interspinous spacers. So this one's called the X-stop. This was one of the first ones. And what this does, it goes in between, you can see it better over here on this other device, but it goes in between the spinous processes and it acts like a bumper, if you will. So what happens when you put this in, it keeps the spine from extending backwards when you move. And so it kind of distracts it a little bit. Now, we don't use these anymore. There was a lot of problems with them. They'd pop out of place, or you'd get, or it would cause breakage of the spinous process. And this is a more advanced technique called the Coflex. And this is actually like a spring. So it attaches to the spinous process right here. And it actually allows you to kind of move a little bit more. And in the right patient, it can be helpful. But again, not all of these is not something you do all the time, but they can be outpatient surgery, and it's not very invasive, and it might prevent you from having a fusion. All right, so we also have to talk about the outcomes. And again, I use this evidence-based guidelines from North American Spine Society. So what you need to know is that when you do decompressive surgery, it is suggested that it will improve outcomes, particularly with people who have moderate to severe symptoms. What are severe symptoms? Well, you can't walk more than maybe 100 feet, or you have to stop a lot, or your legs go numb on you, or you're having lots of weakness in your legs, or it just affects your function so much that it's affecting your quality of life. And when all else fails, know that surgery can be helpful. Now, they have looked at comparing the evidence when you do interspinous processes, and this is not something I do a lot of, but it is in the right patient can be helpful. They didn't find that you could recommend either for or against this. So it's not to say that it's not helpful, but it's just not, there's nothing definitive to say that you should do this all the time, but in the right patient, again, it can be helpful. And also, if you don't have any instability and you have mainly leg pain, just decompression alone is good enough. You don't have to add a fusion or anything of that nature. And most patients will get about 4 years of relief of their symptoms. And so you get good outcomes in a large percentage of patients. And what I tell my patients is you get about 85% chance of success in relief of pain the first year. There's about a 15% reoperation rate. And if you can get to 1 year out, then most of the time you're going to do well. But you got to remember, your spine is like a chain, and we can fix one rusty link, but other links get rusty over time. So you can get other areas that can develop the problem. So, but just know that the surgery can be helpful in the right patient. In the cervical spine, we also have spinal stenosis, but as I told you earlier, the stakes are a bit higher because you're dealing with the spinal cord. So again, this is a cross section of this. And here's your spinal cord all squeezed up against the lamina due to this bone spur, if you will. And you can see that it's kind of pinched right here using the hourglass analogy. And this is an even worse case. This is a patient that's got myelopathy and their spinal cord looks really pinched off, and it's actually changing colors, which shows that it's damaged. So this is something that would cause a patient to have trouble standing and walking, have balance issues. So that's actually fairly severe spinal stenosis. So again, we have multiple solutions, and many of the solutions that we have for the cervical spine are similar to for herniated disc. And again, this is the gold standard that we would use right here. But sometimes you have to do more. And so a corpectomy, all it means is that you're removing the vertebral body. So corp or corpus means body. So you're actually cutting away the body, and it requires more bone. You can also do this through the back like a laminectomy. And there's also an elegant solution called a laminoplasty, which I'm going to show you what it is, where you actually preserve the bony elements, but you place a door stopper in that keeps the door open. All right, so here is a patient that's got actually spinal stenosis of the smaller foramen. And then what I use now is actually, I use these more advanced implants made out of titanium that allows bone to grow into it. And so you don't have to use allograft bone. So again, this is similar to what I showed you before. A laminoplasty is basically where you make a cut in the lamina, you break it on one side, that's what that little line is. You cut all the way through, and then you open this like a hinge, just like a door. And then you got to put a little door stopper in to keep it open, and you can see how much room you have there. So you have to get about 10 millimeters of opening here to effectively improve the spinal canal by 20 millimeters. And then this just shows you the little door stoppers that I use. This is actually an intra-op or an operative or surgery photo. And they're little tiny screws that screw into the bone and keep that lamina open. And again, the outcomes are good, 85 to 90% relief of pain. Myelopathic patients can improve their spinal cord function, but the worse the myelopathy is at the time of presentation, the less recovery is expected. So patients who come in with myelopathy and are practically in a wheelchair and cannot walk very well, they may not get a lot more function from that, but you want to keep them from getting worse. And really the choice of approach has no difference in outcomes, but really it depends on other factors when you share in the decision between the patient and the surgeon. The last diagnosis we're going to talk about is spondylolisthesis, which means slippage of the spine. So spondylo means spine, listhesis means slippage. Some people call it a slip disc. And there are many causes of spondylolisthesis, but the most common ones we're going to talk about are the degenerative type and the isthmic type. The degenerative spondylolisthesis happens as we get older, and it's due to a lot of degeneration of the facet joints. And I tell patients it's kind of like having a bad ball joint in the front end of your car. The steering wheel gets a little bit wobbly and things get sloppy, and then it causes spinal stenosis. Isthmic spondylolisthesis is actually a stress fracture that occurs in the lamina, and it's usually due to chronic stress and typically develops in athletes such as football players, soccer players, basketball players, tennis players. I've seen it in just about anybody, even in gymnasts and dancers. And this may occur and you may not even know it, but it may not become symptomatic until you get older in life. So this just is a picture of a degenerative spondylolisthesis. The joint is real arthritic and it allows the vertebra to slip forward. So you can see how it is out of a line here. This is what it looks like on an x-ray. And this is what the spinal tube looks like with the spinal stenosis, because these joints, which are the bad ball joints, are causing problems. This is the isthmic variety, which means that there's actually a crack in the bone, which you can see right here. And it also slips forward. And here it pinches on the nerve out through the neuroforamen. So your solutions for these is typically you have to do a fusion and you have to put screws in there. All fusion means is that you're welding 2 or more segments of the spine together to stabilize it, but also take pressure off your nerves. This can be done classically from the back, either open, or you can do a more minimally invasive approach. And this is typically called a P-lift or T-lift, if you've ever seen those words. And the nerves are decompressed directly. It can also be treated from the front of the spine, which may be a little bit less invasive, which is called the anterior lumbar interbody fusion, or from the side. And the nerves here are decompressed indirectly because you're making the spine a little bit taller and taking the pressure off the nerves, but you're not looking at the nerves. So this is just a patient who's had a laminectomy and a fusion, and for treatment of a spondylolisthesis. So all you do is put the screws in and you fuse it together, but you're not putting in anything in the disc space. When you see the term PLIF or TLIF, you're meaning you're doing something in the inner body, which means between the bone. This is the vertebral body. And so you can see now there's a little spacer placed into the disc, and this is like a jack. And then you still put your screws in to hold it in place. So this is what an interbody fusion looks like. And it actually, you can see that here's the neuroforamen, and it's actually a lot bigger now. This is an anterior lumbar fusion. And so hopefully you can get an idea that we're coming in from the front of the spine this way. So the thing you have to deal with here is you got to deal with your aorta and the blood vessels here. If you remember that very first slide I showed you that had those blood vessels in the way. So this is just a device that goes in and treats it from the front. And then the lateral fusion means that you come in through the side. So you put this device in through the side, which you can't see it as well. These little markers here show you where the implant is, but then these screws are put in through small incisions in the back. So this is actually a minimally invasive approach. So outcomes for the treatment of spondylolisthesis is actually very good when compared to decompression alone when you add the fusion. And you can do the fusions actually with or without instrumentation. Although I think instrumentation allows people to get better quicker and improves their function faster. And however, the instrumentation by and of itself doesn't necessarily make the outcomes better in the long run, but the key is that you got to get the spinal stenosis treated. And so, but just know if you have this surgery, the chances of that you'll do pretty well with it in the long run. And the same thing goes for isthmic spondylolisthesis. The main thing that people talk about when they have a fusion, there's always worry that there's going to be some degeneration higher up, but the evidence-based guidelines say that there's not enough evidence to show that you're going to get degeneration. So don't be afraid to get a fusion because it may not necessarily affect the long-term outcome in the end. So one final slide to talk about before we move on to the question and answers is what to expect from surgery should you have it. Well, the first thing I want to say, if the patient and the diagnosis and the surgery are right, then outcomes are actually pretty good or better for relief of pain in your arm and your leg. And my philosophy is I try to treat arm and leg pain because I can be more predictable, but many times the back pain can get better. But just know that it's all about the right diagnosis and surgery. And also what I tell patients, no matter how invasive or less invasive, most surgeries take about 6 weeks to get better. And most people are up and moving right away. Now, back in the day when Mixter and Barr did this discectomy, you'd probably lay in bed for about 6 weeks. Well, we get patients moving right away because motion is life, and we don't want you sitting around. We want you to get better. In most patients, surgery can be performed as an outpatient. Sometimes it requires an overnight stay. Sometimes you can be discharged from the recovery room, but it really depends on a lot of factors as to who can go home right away or not. And sometimes if you have some medical problems, we might need to watch those a little bit. Most of the time, patients can start driving again when they're not taking pain medicine and they can comfortably get in and out of their vehicle. Most patients are off their pain medicine within a week. And a general rule of thumb for return to work is usually within about 2 to 6 weeks, if not sooner, but it really depends on the type of job. And most patients are back to full activity within 3 months. So to summarize, and I know we spent a lot of time talking today, but we've learned about our 3 objectives. We've learned about the anatomy of the neck and the low back that contribute to the problems. Then we've talked about the 3 most common diagnoses, which is herniated disc, spinal stenosis, and spondylolisthesis. And then we learned about the different surgical options that you can talk about with your surgeon for these common spine problems. Hopefully, I met my objectives with you and you've learned a little bit of something today. And I really appreciate you for your time spending our evening with us. And I think Carrie's probably got a few questions here, hopefully, for us to talk about. And so we're going to go ahead and move on to the question and answer session here. And again, thank you very much. In my opinion, no, because surgery for back pain usually has different problems. I mean, the goal of endoscopic surgery is to relieve pressure on nerves. It's not to say that there are some types of endoscopic surgeries where they actually go into the disc directly and they try to destroy the disc and make the tear in the disc get better. But my philosophy is that spine surgery is more about trying to take care of the nerve pain. So I would say most of the time, if you do have endoscopic surgery to treat back pain more than leg pain, there is a chance that you may not get as much relief as you think you would. So hopefully that answers your question. But endoscopic surgery in my hands is more about trying to get rid of nerve pain. As we talked about in the outcomes, there is a small subset of patients, about 25%, that can have chronic pain down their legs. And we already talked about the recurrence rate. So I'm going to make the assumption in this, your question, which you're basically asking, your husband had 2 surgeries, and he still has a lot of leg pain. So let's talk about this from the standpoint of what happens when your nerve gets compressed. So think of your nerve like a fiber optic cable that plugs into your TV or plugs into something. And if you were to take that cable and look at the end of it, there's lots of these little filaments that are in there that shine the light. But sometimes when a fiber optic cable gets bad, you'll get dark spots within that cable because not as many of the fibers are working. And then if you have the fiber optic cable goes completely dark, that means all of the filaments have gone bad. So a nerve is made up of millions of little fibers like the filaments within a fiber optic. And when you get compression on that nerve, some of those little nerves get damaged. Sometimes they can heal up. Sometimes they don't heal up, even when you relieve pressure on those nerves. And so those damaged nerves can continue to fire off and cause pain down your leg. So the unfortunate thing sometimes in patients that have chronic nerve pain is that it actually comes out of the spinal cord and the brain. And as long as there's nothing pressing on the nerve and you have the nerve pain, further surgery may or may not be beneficial unless there's something actively compressing on it. But there are other things to try, such as spinal cord stimulators, which is a way to try to mitigate that pain for the long term. So without knowing exactly what your husband's diagnosis was specifically, sometimes more surgery does not necessarily mean a better outcome. So if there's a mechanical cause still present and instability and not a significant amount of weakness or nerve damage, then the more surgery may be helpful. But sometimes there comes a point of diminishing returns and you have to look for other alternatives to relieve that pain. All right. So although this talk was about surgical solutions, the question is something less invasive than surgery, such as a shot, meaning like an epidural steroid, a reasonable thing to continue first? And then is the MRI the deciding factor? Well, let me talk about the MRI first. So many times patients will come in with an MRI that shows lots of pathology in their back. The radiologist makes a lot of observations and they're going to say there's severe stenosis of this foramen, there's a herniation here, there's a nerve compression here. And sometimes these patients have no symptoms at all. So I use the MRI as a guide to couple with the patient's history and physical examination to precisely identify where the nerve is. So just because you have an abnormal MRI does not mean that you have to have surgery. It just helps you to plan out where your problem is. So that leads to your first part of the question, which is it appropriate to get an epidural steroid injection or some other injection? So my philosophy, I'm a spine surgeon. I believe in conservative treatment. I try to get patients better without surgery. And sometimes some of the most rewarding patients are those who have a herniated disc and get better on their own without having any surgery. So when you talk about surgery, there's what's called a relative indication and an absolute indication. And relative indication means that you got a problem that surgery could help, but it doesn't have to be absolutely done. So whether a physical therapy or medications or an epidural injection is chosen as the form of treatment, it just depends on how severe you are at the outset. The evidence-based medicine, when you use those clinical guidelines, does show that epidural steroid injections can be beneficial. And so what it's doing is relieving the pressure on the nerve by reducing the swelling. It doesn't do anything to the disc herniation, but sometimes your body can take care of those disc herniations. So as long as you don't have anything like a foot drop or severe weakness or severe dysfunction, there's nothing wrong with trying an epidural steroid injection first. And so many times, if a patient comes in and they have acute onset of pain within a couple of weeks, I would probably try to go with a non-operative approach first to get them better. And I usually don't consider surgery until it's about 6 to 8 to 12 weeks out, unless the patient has such severe pain that they can't even get out of bed. So the answer to your question is yes, there's nothing wrong with trying a shot first. And I would talk about those options with the patient. All right. So the question is chronic back pain for, I presume they have a spondylolisthesis. I'm assuming that, and physical therapy has not helped. And is it okay to move on with chiropractic treatment? So what is the purpose of physical therapy? Well, therapy. So if you look at your spine and you have the hard parts, you have the hard parts of the spine, which are your joints and the bones, and you have the soft parts of the spine, which are the muscles. The whole purpose of physical therapy is to strengthen the muscles of your stomach, your legs, and your back so that it supports the hard parts of your spine that have failed. And so chiropractic treatment can be helpful. I mean, the evidence-based guidelines show that physical therapy may be beneficial, but it doesn't cure. It's just trying to help you become more functional. Chiropractic treatment actually may have some benefit for patients who have acute pain, because realigning the spine might help relieve some of those muscle pressures. But it's not going to cure the problem. It might give some partial relief. And I do caution patients if they have severe nerve impingements that you want to be careful with any kind of high speed type of manipulations. But, you know, again, why physical therapy didn't work for your particular problem is hard to know. Maybe you just have a lot of instability that you could see on x-rays, or that joint may be so arthritic that you might have to consider other options. But there's nothing wrong with trying physical chiropractic. It's just a different type of physical therapy. You know, if it helps you, then that's good. It's good to go, but it doesn't work for everyone. You would have to be the judge of whether it gives you value. And hopefully that answered your question.